I'm Edwin. I'm one of the PGY2s. Sorry, I'm a little tired. I did the mistake of working overnight before this. So juniors and everyone else around don't do the same mistake I did. But welcome to topic review for ID. So we're going over a few questions. So let's get started. So question number one, we have an 8-year-old girl is brought to the office by her mom for a possible evaluation of TB. The patient's younger brother was actually recently diagnosed with active TB. Patient has been in close contact with her brother, but has had no fever, night sweats, cough, anorexia, or weight loss. The patient has not received the Bacillus vaccine, but is up to date with the rest of her vaccines. Vital signs and exam are pretty much unremarkable. Her interferon gamma assay ends up coming back positive, but her chest x-ray is normal. Cultures from the aspirate of her younger brother show acid-fast bacilli resistant to isoniazid. So which of the following would be the most appropriate management for this patient? So we have A, essentially quadruple therapy for 2 months, then isoniazid and rifampin for 4 months. B, repeat the interferon assay after 2 months. C, obtain a sputum acid smear and culture. D, treat with isoniazid for just 9 months, or E, treat with rifampin for only 4 months. Any takers?
I guess it's probably D, but I thought that they had changed the timing to you can do it for less time for the isoniazid.
Mm-hmm. So you're okay. So we're going with D. We're going with D. So let me go ahead. The answer actually in this case would be E. It would be treating with the rifampin for 4 months. So this patient has a positive assay, right, but has no other symptoms. As said in the question stem, had no chest pain, had no cough, no weight loss, no other chest X-ray findings as well. So this indicates that this patient most likely has a latent TB infection. However, given the contact with the brother with this known resistant strain, right, the first line therapy should be, in this case, which should be rifampin for around 4 to 6 months. First D would be the right answer if this patient wasn't in contact with a brother that had this resistant strain, because first line therapy usually is with isoniazid. The other choices, including A, for quadruple therapy, were not correct because active TB, those would be in cases of the patient had active TB. That's when you would consider starting multi-drug therapy. And then the other choices for B and C, the sputum acid fast culture and stuff like that. That's mostly also for patients with active TB. And usually with for choice B, you wouldn't need to repeat. You wouldn't need to wait for 2 months to repeat the exam. All right. Then we move on to the next question. We have a 31-year-old woman presents to the ED for mild nausea for the last few weeks. Urine HCG results positive with the rest of her workup unremarkable and IUP confirmed in the ED. The patient also endorses that she is HIV positive and states that she's currently on triple combination antiretroviral therapy. As you're getting ready to discharge this patient, she asks if it's safe to continue taking her medications for HIV. Which of the following is the appropriate recommendation for the patient? A scheduled C-section should be performed at 38 weeks. B, antiretroviral therapy is indicated only during delivery. C, antiretroviral therapy should be discontinued if her viral load is undetectable. D, to decrease the risk of teratogenicity, antiretroviral therapy should be reduced to monotherapy. Or E, triple antiretroviral therapy should be continued throughout pregnancy. Oh, we got some answers in the chat. Sorry, go ahead.
Is it D? I thought zidovudine was the only one that was okay in pregnancy, but correct me if I'm wrong.
So the right answer in this case is actually E, triple antiretroviral therapy. It should be continued. It is safe in pregnancy, mostly because it's treating maternal disease. It's preventing the perinatal transmission. Really, only modification of any treatments should be avoided in the initial trimester because you don't want to cause any sort of drug resistance. You don't want to lose any sort of viral suppression the mom might also have. And you want to decrease any sort of perinatal transmission. In terms of the other choices, choice A and B, right? In terms of choice A, which was talking mostly about C-section, really changing delivery modality is really mostly based on the third trimester viral load. So we wouldn't really say anything early on in the pregnancy. You would have to wait until the third trimester and determine how bad their viral load was. And in terms of choice B, in terms of the intrapartum antiretroviral therapy, it is indicated because you want to, again, decrease the risk of perinatal HIV transmission. Any questions on that? All right, we'll move on to the next one. So the third question, a 4-year-old girl is brought to the office due to a cat bite on the right thumb. The bite occurred approximately an hour ago. The parents washed the girl's thumb with soap and water before bringing her to the ER. The cat is fully vaccinated. The patient has very minimal pain. Exam just shows a single puncture wound on the pad of her right thumb. No erythema, no drainage. Range of motion is normal. Which of the following would be the best next step in management? We have A, observation, B, prophylaxis with augmentin, C, prophylaxis with azithromycin, D, prophylaxis with clindamycin, or E, prophylaxis with Bactrim.
C.
Yes. Oh, wait, sorry. It would be B, actually. So the right answer in this case is B, augmentin. So cat bites are high risk bites, right? The feline teeth are very thin and sharp, so when they bite down, they can cause deep puncture wounds that can cause bacteria to go deeper into the tissue. Usually, depending on the wound, you would most of the time leave them open and let them heal on their own. And then antibiotic prophylaxis should be provided. Augmentin is actually first line because it provides coverage against the gram negatives, the gram positives, and also the oral anaerobes. Azithromycin is used specifically for catch scratch disease, so it could get confusing in these cases. And with catch scratch disease, as we talked about in the small groups, that's more with the lymphadenopathy that they present. And you would use azithromycin in that case. But if it's just a regular bite, a bite wound, and you just want to do prophylaxis, you would choose augmentin firsthand. In observation, like choice A just said observation, usually, like I said, because the puncture wounds are deeper and the feline teeth are thin and sharp, you would want to provide antibiotic prophylaxis rather than just observe.
Yeah, just to add to that, the cats have in their mouth, as you said, all these organisms. One of them they have is a very kind of invasive Pasteurella.
Mhm.
So, and augmentin really has great coverage against that.
Thank you, Dr. G. Question number 4 now. We have a 55-year-old man comes to the ED, has had 4 days of worsening fever, cough, chest pain. Cough is productive of yellow sputum, sometimes streaked with blood. Of note, the patient underwent a stem cell transplant 6 weeks ago and is currently on immunosuppressive therapy. He's receiving infectious prophylaxis with a few set of medications already. So he's getting valganciclovir, fluconazole, Bactrim, and levofloxacin. He's currently febrile with a heart rate of 105 and satting 91% on room air. Chest X-ray at that time just shows an infiltrate in the left upper lobe, and then the CT scan a subsequent CT scan shows a cavitary nodule with surrounding ground glass opacities in the left upper lobe. So which of the following do you guys think is the most likely cause of this patient's current condition? So we have A, Aspergillus, B, CMV, C, Legionella, D, pneumocystis, or E, strep pneumo.
A.
Yes. Perfect. So The answer in this case is Aspergillus, right? So this is a patient who's coming in with pretty intense immunosuppression, right? And these patients will be at risk for pulmonary aspergillosis. Usually presents with a triad of cough, pleuritic chest pain, hemoptysis, and the imaging, as it said in the question stem, usually shows cavitary lesions with these ground glass opacities, right? The other choice is CMV, can cause ground glass opacities as well. But in this case, this patient was being already prophylactically treated with valganciclovir, so it would be less likely. Legionella can present similarly with pulmonary complaints, but they also can sometimes have GI symptoms. So that's something to distinguish with Legionella, right? They can present with nausea, vomiting, or diarrhea. And then pneumocystis is also another common infection that's seen in immunosuppressive patients, particularly the HIV and AIDS patients, but this patient was also receiving the adequate prophylaxis at the time. So the only choice that made sense in this case was Aspergillus. And this is an example of how the cavitary lesions can look like on CT. All right, question number 5. We have a 7-year-old girl is brought to the ED by her parents in August due to fever and lethargy. So the patient has had intermittent fever and headache for the last few days. Her headache worsened in the last 24 hours and she's vomited twice. The family recently returned from a week-long camping trip. Temperature is 102, heart rate is 118, respiratory rate is 24. The patient is up to date on all vaccines. She's currently disoriented, has positive nuchal rigidity with hyperreflexia in the patella, as well as a positive Babinski. Several insidious bites are seen on her extremities. So which of the following do we think is the most likely etiology of the patient's condition? So we have Borrelia, CMV, herpes, simplex, measles, or West Nile virus.
E.
E.
West Nile.
So some people are saying West Nile, some people did someone else say D as well? I think measles. In this case, so this one's a little trickier. In this case, the correct answer is E, is West Nile virus. So this patient is presenting with altered mental status, nuchal rigidity. So she's showing signs of meningoencephalitis, right? In children, when we talk about pediatric patients, enteroviruses are usually going to be the most common cause of viral CNS infections, followed by the herpes viruses and the arboviruses. In this case, West Nile virus is an arbovirus. West Nile virus, however, in this case, it's important to take a look at the presentation and the history that the patient provided. So West Nile virus is transmitted by mosquitoes, usually in the summer. This patient is presenting in the summer, has multiple insect bites on her extremities that would make West Nile virus kind of the most concerning one. HSV is very common, but like I said, with insect bites, we would think of West Nile more likely. Measles encephalitis can occur, but usually you would expect the initial prodrome of cough, coryza, conjunctivitis, and maybe the rash that presents before the onset of the encephalitis. And it's unlikely in a patient who's been fully up to date on all their vaccines. And then lastly, choice A was Borrelia, which for Lyme disease would also be one to be considered of. But again, this would present usually much later in the Lyme disease stages. So you would expect her to have already had, peripheral neuropathies or arthralgias, or maybe the erythema migrans rash associated with it prior to presenting like this. Question number 6, we have a 53-year-old man complains of acute onset of vomiting during a Caribbean cruise. He has had multiple episodes of vomiting since the morning, as well as an episode of watery diarrhea, mild headache, and muscle pains. 10 other passengers have similar symptoms. His temperature is 100.6, and the remainder of his exam is unremarkable. Stool cultures are negative. Which of the following is most likely the cause of this patient's current condition? So we have A, Campylobacter, B, Clostridium, C, enterotoxigenic E. coli, D, Listeria, and E, Norovirus. And yeah, I guess COVID could definitely be an option, as Mark put in the chat nowadays. Oops, sorry. Yes, everyone in the chat is correct. E would be the most likely. So norovirus is the most common cause of any sort of epidemic gastroenteritis. It's usually the most common presentation that they always write in question steps is going to be in a cruise ship. It's spread via fecal oral contamination. These symptoms can start suddenly, and they usually last around 48 to 72 hours afterwards. And usually you only need supportive care. This is a cool chart that I was able to get from UWorld actually. And it just shows a good, I liked it a lot because it just shows you kind of depending on the symptom, what bugs to look out for, right? So the vomiting predominant, you can think about Staph aureus, Bacillus cereus, and then you have the different types of diarrhea, as well as the other extra intestinal symptoms. The other choices, Campylobacter can often present with inflammatory diarrhea, so you would expect to have some sort of bloody diarrhea. The enterotoxigenic E. coli is the most common cause of traveler's diarrhea, but less likely a cause of diarrhea in outbreaks. So if you see 10 or more, a bunch of people getting the same symptoms, it's more likely norovirus rather than the E. coli. And then listeria is a very rare cause of epidemic gastro. It can sometimes present with other symptoms other than GI symptoms, but you would need a stool culture to diagnose that. Okay, oops. We can move on to the next question, number 7. So we have a 38-year-old male patient with no previous medical problems presents to the ED with a complaint of slurred speech. He states he recently returned from a camping trip in Massachusetts. His picture below shows his face when he's asked to smile. Which of the following medications will treat the underlying condition? So we have amoxicillin, azithro, doxy, tetracycline, or vancomycin. TPA, no, definitely not TPA in this case. The correct answer in this case would be a good old doxycycline. So this patient obviously is presenting with a clinical picture consistent with Bell's palsy, which is paralysis of cranial nerve number 7 or the facial nerve. Given his recent camping trip, right, Lyme disease is most likely the underlying cause. And doxy is going to be your treatment of choice. Doxy also helps treat a bunch of the other tick-borne diseases, as we spoke about in my small group. So it's definitely useful to give early on. Amoxicillin can be given, but it's usually reserved for pediatric patients and those that you don't want to give doxy to due to the side effects of doxycycline that include like the teeth staining and stuff like that. Azithromycin is not useful for Lyme disease. And then the other choices, which were tetracycline and vanc, are also just not used in treating Lyme disease. But so that's just an important thing to look out for. Obviously, the big thing here was his camping in Massachusetts was the big sign. Right, then we move on to question number 8. So a 23-year-old woman recently returned to the US after serving for 2 years as a Peace Corps volunteer in West Africa, presents to the ED now with several weeks of fevers, with abdominal pain, poor appetite, and weight loss. On exam, she's afebrile and well appearing, but it does have some tenderness to palpation in her right lower upper quadrant and a palpable liver edge. Her labs show a mild leukocytosis and transaminitis. A CAT scan shows the following. So which of the following is the most likely etiology of this patient's symptoms? So we have A, cysticercosis, B, entamoeba histolytica, C, Hep B, D, Staph aureus, or E, yellow fever. So we have some in the chat already. So yes, the answer in this case is going to be B, entamoeba histolytica. So again, this entamoeba histolytica, it usually presents with the presentation of fever, of right upper quadrant pain, weight loss, and then the big thing that it usually shows up with is the hepatic abscess, which was seen in the previous slide before. And it's usually in patients who have resided in an endemic area for quite a while. The infection occurs again via fecally contaminated food, water, or hands. Treatment for entamoeba usually involves Flagyl, and then usually a paramomycin or idoquinol. The other ones to think about, cysticercosis can cause enlarging cysts, usually more in the muscle, the CNS, but not really in the hepatic tissue. And cysticercosis is more associated with like ingestion of contaminated pork. Hep B, like we know, is mostly by infected blood or body fluids, but it usually presents not really with hepatic abscess, more with a transaminitis, a jaundice, a right upper quadrant pain. And then yellow fever, which was the other choice, usually presents more like a flu-like illness, and no real hepatic abscesses are associated with yellow fever.
I've actually had amoeba, and usually what happens is within a couple of weeks, usually not right away, but of leaving the endemic area, you'll get this. It'll be an invasive type of diarrhea. So it'll have mucus and blood and tenesmus. If you're unlucky, you can get the abscesses. You don't always do. I didn't, but you can get the abscesses. And again, treatment is acutely metronidazole, and then you could add in iodoxyquinol or paramycin to kill the cyst. If not, it can came back, which happened to me. I just took metronidazole, thought I was cured, acted stupid, didn't want to take any more drugs, and it came back. And then I had to get, take iodoxyquin.
Thank you, Dr. G. Always good to hear personal experiences. We learn the best from those. Question number 9. Which of the following is true regarding infection with Plasmodium falciparum? So A, chloroquine is the treatment of choice worldwide. B, large numbers of mature parasites are usually seen on peripheral smear. C, older adults have a higher risk of residual neurologic sequelae. D, parasites may remain dormant in the liver and reactivate after months or years. Or E, severe disease has up to 30% mortality rate even with aggressive treatment. This one was a tricky one for me.
Maybe D.
So D is one I thought was the answer to when I was first doing this question, but actually the answer is E. Severe disease has up to 30% more mortality rate even with aggressive treatment. So with Plasmodium falciparum, it's out of all the malarial species, it's actually the most likely to cause severe and life-threatening disease. It can cause severe malaria can manifest with severe anemia, acidemia, kidney injury, ARDS. You can have the CNS symptoms as well, as seen here in this picture that's showing petechiae that was due to malaria. The other choices, choice A was talking about chloroquine. Falciparum actually has a very high chloroquine resistance rate. So chloroquine is usually the drug. If it is falciparum, we usually do not want to give chloroquine just due to the high resistance rates of those. In terms of D, in terms of the ones that remain in the liver, those are actually Plasmodium vivax and ovale. Those are the two ones that actually remain in the liver and will require some extra treatment to get rid of those, the remaining parasites in the liver. And then the other choice talked about kind of older patients having worse outcomes. It's actually the opposite. Up to 33% of children will actually end up having permanent neurological sequelae compared to like 5% of adults with malaria by Plasmodium falciparum.
Also, pregnant women are very, very much at risk, and they'll get the encephalitis very quickly.
All right, and then the last question. So we have a previously healthy 45-year-old man who works in taxidermy on a farm. He presents with 5 days of progressive fever, body aches, chest pain, shortness of breath, vital significant for tachycardia to 102, respiratory rate of 30, satting 88% on room air, temperature of 38.2. His exam shows a small eschar on the dorsum of one of his hands and some axillary lymphadenopathy on the ipsilateral side. His chest X-ray is shown below. Which of the following do we think is the most likely etiologic agent? First choice is Ancylostoma caninum. B is Babesia microti. C is Bacillus Anthracis. D is hantavirus. And E is Toxoplasma gondii. Any takers? I'll take a look at the chat. Good. Eli said C. C is correct. In this case, this is a case of Bacillus Anthracis. So Bacillus anthracis, it's a gram-positive spore that also forms rods, and it causes the big distinguishing feature of Bacillus is that it causes both pulmonary and also cutaneous symptoms. It's usually associated with like animals like sheep, cows. So it is usually going to be associated with people who are, farmers and who are dealing with animals in close proximity. The cutaneous symptoms usually can start off just as a simple painless macula, and then it eventually will develop into a vesicle, then an ulcer, and then it form this eschar, which is characteristic of Bacillus anthracis. And then the pulmonary components can be much more severe. It can present with pulmonary edema, as seen in this patient with their X-ray, or it can be very severe mediastinitis, and can be very fatal as well. Patients who present with very severe disease are going to be usually treated with a fluoroquinolone or doxycycline, and then you add on clindamycin and rifampin for that. The other choices that really were spoken about, hantavirus can cause also similar pulmonary syndrome, severe pulmonary disease. But for hantavirus, it's more associated with interactions with rat feces or rat bites. So that's kind of the main association with hantavirus. And then I believe toxoplasma, like we said, is mostly with undercooked meat, and that's associated with exposure to cat feces as well. But it has no real severe pulmonary manifestations.
One thing to know about the Bacillus anthracis, when you see anthrax, very characteristic is edema. So even when you see the lesion, and when I worked in Venezuela, I saw, and once in Haiti, I saw the cutaneous lesion. They really, have a lot of swelling around it. I remember this guy in Venezuela, his whole half of his face was like 10 times the size of the other half of the face where the lesion was, this necrotic lesion. And then even when you see it in the pulmonary, you'll see they'll have these huge swollen nodes. They'll have, like you mentioned, edema around. And again, there are several ways to treat it, but Cipro, especially if you think it's the engineered, you want to think of this also if with a terrorist who may send a powder, and we saw that, and they may be engineered and more resistant. So Cipro, the fluoroquinolones, as you mentioned, is the drug of choice. And you have to take it for months.
All right, thank you, everyone. And then again, special thanks to Dr. Gerensheimer and Dr. Paul Hein, who helped me set up all this. Thank you, guys.